Thanks for doing that. I'm sure you've come up with all sorts of different things. But here you will see the sorts of things that I suspect featured, and maybe you've got other things too, which is important. The decisions the staff made, whether they were experienced in perhaps thinking about the social situation of this child, or understood perhaps some of the cultural challenges that were present. Whether they were in fact expert in looking after complex diabetes, or perhaps were covering for somebody. There are also the things to do with the patient themselves, what sort of family education level there is from the point of view of understanding how to manage diabetes well, and whether the child was confident in managing, or perhaps a bit obstructive or not familiar with what was needing to happen. And then, of course, there's all these sort of other things that are surrounding that child and their family. The school staff, maybe other relatives who do or don't have knowledge of diabetes, the community support, perhaps clubs or GP. So to be honest with you, all those things need to happen. And so when we look at this complex system, as I'd like you to now look at the slide, you can see that even if we got the ward round right, even if we made the right decisions because we're really experienced doctors, if that family's particular circumstance isn't understood, if the community or the GP or the school don't do the things that we think and they know probably need to happen in order to support the ongoing care of this child, all our best efforts may well fail. The point is that multiple things need to happen. And this is where improvement methodology can really be beneficial, because we know we have to choose to improve lots of different things. The question is, where do we start? We can't improve everything at once. So where should we go first? Because we think it's important, we think we can try something out pretty quickly, and we've got a strong sense that it will be successful. And anyway, we're going to look and see and make sure it is. So complex systems have direct and indirect influences constantly. That makes it a challenge. So here is how you might build your project around this child. So instead of having a root cause analysis and a whole long list of things that need to happen, you could build what we would call a driver diagram. And here is an example of a driver diagram we've built around this particular situation. We've decided we're going to reduce admissions, certainly multiple admissions, over the next 12 months for this child. And we're going to reduce them by 80% in 6 months, and then hopefully absolutely reduce them by 100% down to very unusual and rare cases by 12 months. We're going to address things in the hospital, in the blue box. We're going to address things to do with the patient. We're going to address things to do with the home environment, and then we've chosen to say community resources are separate. And these are all the ideas we've had, you can see in the blue boxes. Because we think that they will make a difference. A discharge checklist, so we've checked everything. Self-care, so we pay a bit of attention to that, or at least one of the nurses is specially coached to help us with doing that. The handover to primary care. And so you can see we've got a lot of things going on here. They won't all happen together. Some of them will be perhaps given to small teams, small groups of our team. Others we're all working on together. Some will be easily adapted from something we've already got that we need to see happening regularly. Others, maybe we need to kind of look around and think a bit longer about how they're going to work. The point is that quality has multiple components. There are, of course, the socio-economic situations for children. There are also the social determinants of health, some of which we can influence and some of which we need other people like social workers and schools to work with. But then there's the important components of quality: safety, timeliness, effectiveness, efficiency, equitable access and equitable consideration, and making it person-centered and person-focused so that the people we're working with and for, the patient and their family, absolutely are partnered with us in what we're doing. We call that the STEEEP curve, because it is a steep curve to address all of those. No point in making it safer, but forgetting about equity or person-centeredness. So it's important consideration to have when you're working in complex systems.